Hello everyone, and welcome back to my channel. My name is Dr. Stephen Roth, and I'm a board-certified oral and maxillofacial pathologist. And today's video is a little bit different from my other videos that I've made in the past. And that's because rather than being a short, digestible, focused video, this is going to be more long-form and comprehensive. I originally recorded this video for my dental students, so this video is really great if you're studying for an oral pathology exam or a board exam or an in-service exam. And I also will be breaking this video down into different chapters. That way, if you want to go back and review certain entities, you're welcome to do so. All of the cases in this video are either my own, and if they aren't, then they're expressed on the slide themselves as to where I got it. Most of which are from my friends and colleagues and residents, and a few are from select journal articles. I'll be putting these more long-form videos together in a series called my Ultimate Review Series. You can check that out at the link above. And finally, we've got to quickly go over that disclaimer, and that is that all of the opinions expressed in this video are mine and mine alone, and do not represent any organization that may employ me or that I may belong to, and also that this video is not intended as medical advice. It's for educational purposes only, and should you have any questions about your oral or systemic health, please see your nearest oral or systemic healthcare provider. And with that being said, I'll turn it over to my recorded lecture. All right, so here we have a presentation on salivary gland disease, and this is specifically non-neoplastic salivary gland disease. So this presentation will not include any benign or malignant tumors. This primarily focuses on reactive and inflammatory and a few metabolic processes that occur within salivary glands. The first is salivary gland aplasia. And this is exceedingly rare, exceedingly rare. It is a developmental anomaly where one or more major salivary gland does not develop. Most of these cases are associated with a specific syndrome, including Treacher-Collins syndrome and lacrimal auriculodentodigital syndrome, LADD, although this can occur spontaneously on its own. The extraoral appearance of these patients will seem normal, and that's because where the gland should be existing is replaced by fat or connective tissue, so that space is filled. Now, the exception to this rule is if there are syndromic presentations. So, for instance, Treacher-Collins syndrome often presents with zygomatic hypoplasia or absence. So, there is a facial difference noted in these conditions, but if salivary gland aplasia is occurring spontaneously, then their extraoral appearance will look like that of anyone with a salivary gland. The intraoral appearance is very interesting because the duct orifices are absent. So where you would expect to see the parotid papilla or the sublingual caruncle for draining of the submandibular glands, you would not see anything. It would be continuous with the rest of the mucosa. Obviously, if you are missing a salivary gland, you're going to suffer from severe xerostomia and all of the consequences therein, caries, candidal overgrowth, etc. Next is the mucocele, and mucoceles are very common. You are definitely going to see this in your practice. And these commonly occur in children and young adults, but grown adults are certainly not immune to this condition. If you think about why these happen commonly in children, if these children receive anesthesia for a restorative procedure, they are going to be numb and they may not feel their lips and they may be playing with it, and it may lead to trauma that causes a mucocele. Mucoceles occur when the salivary duct ruptures and the mucin from the gland spills into the tissue, and there is a subsequent inflammatory response that tries to wall this off. So the body is exposed to this mucin. It doesn't like this foreign substance that should not be out into the tissues. So an inflammatory response is mounted to try to wall it off and to keep it separate from the rest of the tissues. If the mucin is pulling in the superficial tissues, it's going to look more blue, as is the case in this picture. If the mucin spills deep within the tissue, then it may look similar to the mucosa's color, and it could be mistaken for a fibroma when really it's a mucocele. These tend to be fluctuant, obviously, because of the mucinous product inside of it, and non-tender. So these are usually not painful to the patient. The patient may give a history of this lesion swelling and then popping or rupturing and then coming back. And that's because simply lancing this or performing incision and drainage is going to get rid of the mucin, but it's not going to get rid of that ruptured duct. And the ruptured duct is going to continuously push out spilled mucin into the connective tissue unless it is removed. In fact, the patient in this picture went to the emergency department at the hospital where an incision and drainage was performed, but then this is the appearance approximately 2 weeks later, where obviously it has come back and it's pretty large. The lower lip is the most common site, and up to 80% of mucoceles occur there, and they usually occur lateral to midline. And that is because if you think about the teeth in this area, that's where our sharp canines are. So obviously a lot of trauma can occur if someone bites their lip, and most of that will occur in the area of these sharp canines that are both kind of where the occlusal arch makes a turn to go posteriorly, and then the teeth morphology itself are pretty sharp and can lead to trauma. With that being said, these can occur in other places, including the ventral tongue, which you can see pictured here, the buccal mucosa, and the floor of mouth, which we'll speak about in a little bit. These are exceedingly rare in the upper lip and retromolar pad. This is a really crucial point that you should remember. If you're suspecting a mucocele in the upper lip, you should really think once or twice, because most of the time this is going to be a neoplastic process, such as a monomorphic adenoma or a pleomorphic adenoma or even a leiomyoma. And then the retromolar pad, if you see a mucocele in the retromolar pad, you really have to be suspicious for mucoepidermoid carcinoma. That's kind of the classic teaching that if you see a mucocele in the retromolar pad, it likely is mucoepidermoid carcinoma. So in these two circumstances, you really need to be careful about diagnosing a mucocele, and they definitely need biopsy. The proper treatment of mucoceles is by local excision with adjacent glands and duct. And the reason you have to remove that adjacent gland and duct is exactly what I spoke about before. If you don't remove the gland and the duct, you're going to continuously spill out mucin into the connective tissue, and there's a high probability of recurrence, where if you only remove the mucin and the granulation tissue, it's very likely that that damaged duct is going to continue to spill out mucin. So if you're going to do a surgery where incision is involved, you want to make sure that you're doing the proper surgery and treatment for this condition. I really like this photomicrograph that I took of a mucocele because you can really see the two main components here. In the top portion underneath the epithelium, in this area here, you can appreciate that pooled mucin, the mucin that has spilled out. And this is what you can see clinically. This is the blue bump. And then here, we have our beautiful ruptured duct. This is the source of all that spilled mucin. And you can see all of that mucin coming out. And then you can also see the inflammatory response that's trying to wall off this quote unquote foreign material in the connective tissue. A closer look of that ruptured duct, where you can appreciate that that truly is a salivary duct with our mucin and then our granulation tissue trying to wall it off. And then here's what we see clinically, that blue bump, which is just extravasated mucin under the surface. A ranula is a mucocele of the floor of mouth. And these certainly aren't the most common type of mucocele. They only occur as about 5% of all mucoceles, but they certainly do happen. And the name ranula comes from the Latin word for frog, or rana. And that's because in the floor of the mouth, mucoceles look very much similar to a frog belly, which you can appreciate in this little picture down here, that swelling under the frog's throat looks similar to what you're going to see on the next slide. There is a variant called the plunging ranula, and that's when the mucus and the granulation tissue dissects through the mylohyoid and then enters the neck. To diagnose this, you really need a CT or MRI to prove that this is what's going on. There are lots of other things that enter the differential diagnosis for a neck swelling, and this is certainly one of them, and the way to prove it is through CT or MRI. The treatment for ranula is the same as Mucocele, where you're going to remove the feeding sublingual gland, and occasionally that can be very difficult to do. So sometimes marsupialization will be undertaken, but only if the ranula is small. You really want to make sure, again, that you're doing definitive treatment if you're going to treat this. So removal of the feeding sublingual gland is really the optimal treatment for a ranula. Here's a ranula that I came across in my practice. You can see this blue swelling of the patient's left floor of mouth. You can compare it to the normal other side, and you might appreciate that this looks very similar to that frog belly in the other slide here. Now, this is a case that my colleague, Dr. Andrew Salama, published of a plunging ranula. And you can appreciate in the CT that we have a fluid swelling in the floor of mouth, but then we can see this communication through the mylohyoid and that same fluid swelling occurring in the neck, leading to this swelling under the chin. There are a lot of different entities in the differential diagnosis, but with the CT and the history, we know that this is a plunging ranula. A salivary duct cyst is a true cyst. That means that there is an epithelial lining. In a mucocele, there was no lining. It was just granulation tissue that tried to wall it off. A salivary duct cyst, there is a true lining around the opening in the middle. This can occur in a major gland, which you can see here. This was in the submandibular duct leading to the salivary duct cyst, or it could occur in a minor gland. It looks very similar to a mucocele, and its treatment is excision. You don't need to go after the gland itself. You can just simply cut this off. But this is an example of a salivary duct cyst in a major gland. And this is from my practice, which is a salivary duct cyst in a minor gland. And this was removed. This was excised by me. And you can appreciate that it looks a little yellow. The reason why it looks yellow is because it's abscessed. So this was an opening lined by epithelium. And over time, it filled with neutrophils, leading to an abscess within this duct cyst, and it caused it to look yellow. This was fully excised, patient returned for follow-up, and there was no recurrence. Sialolithiasis or Sialolis are salivary stones, and these are calcified structures in the ducts. So these are very similar to kidney stones, but they occur in the glands. We're not really sure why this happens, but we do know that if a patient has chronic inflammation of their glands or chronic sialadenitis and obstruction, it can lead to the minerals sitting in one place for a long time, which can lead to the salivary stones. So we don't know why they happen or why they happen in certain patients, but we do know that chronic sialadenitis and obstruction certainly promote their growth and their appearance. The submandibular gland is the most common place to see a sialolith. 80% of sialoliths occur in the submandibular duct. And that's because if you think about the anatomy of the submandibular gland is below the angle of the mandible, and its opening is in the floor of the mouth. So in order to get saliva out of the submandibular gland, the saliva must go against gravity upwards on this very long and kind of windy, tortuous duct. If anyone has seen the submandibular duct grossly in a cadaver or when studying gross anatomy, you know that this is a very windy, twisty, almost pigtail-like duct. The other contributing factor is that the submandibular duct has thicker mucus secretions. The parotid duct is almost exclusively serous, which is very thin and watery, whereas the submandibular duct is mixed with mucinous and serous secretions. Since it's thicker and traveling up this long, tortuous path that's windy and somewhat against gravity, it makes sense that it's going to move a little bit slower, more prone to obstruction, and can lead to sialolith formation. That being said, sialoliths can occur in any salivary gland, including minor glands. So you can see this in the buccal mucosa, you can see this in the lips, you can see this in the tongue, though tongue would be exceedingly rare. I've seen it in the buccal mucosa and in the lips, in addition to obviously the major gland ducts, especially the submandibular duct. Now, these may or may not be symptomatic, and that really depends on if the saliva can flow around the stone. If the stone is fully obstructive, then the patient is likely going to have symptoms. And the symptoms come and go and wax and wane, and they are especially worse at meal times. And that's because if you think of Pavlov and his dogs, whenever the dogs were preparing to eat, they would start to salivate. And we're exactly the same way. When we know food is coming, our body prepares by creating more saliva to help us with digestion. And when our body is trying to create more saliva and secrete more saliva, but there's an obstruction, that can be very painful. The clinical appearance of a sialolith is obviously a hard, because it's calcified, submucosal mass in the soft tissue. A radiograph can be a really helpful diagnostic tool for a sialolith, and that's because these are going to appear radio opaque. We're going to see these on radiographs. And on radiograph, it's going to look laminated or layered, like a tree ring. And that's because as the sialolith grows, it grows kind of concentrically in layers, and it adds a new layer on the outside and calcifies, adds another layer on the outside and calcifies, and it creates a really beautiful laminated structure that we see both on radiograph and under the microscope. This is a case that I saw as a resident, where you can appreciate that in the floor of mouth, this little yellow thing at the entryway of the submandibular duct that seems to be blocking it. And this patient did have symptoms, especially at meal times. You can also appreciate that there's a subsequent neck swelling. And that's because this obstruction led to backflow and kind of a traffic jam where the saliva could not escape the duct, leading to a chronic inflammation occurring in the feeding gland. So the gland was becoming swollen because of all of the inflammation, because of the obstruction caused by the sialolith. This patient eventually did secrete that sialolith. The sialolith popped out, and the patient likely swallowed it unincidentally and went back to normal. Here is a case in the literature that is a cautionary tale, right? So if you are taking your routine radiographs before you do a clinical exam, you might see a radio-opaque mass. And in this case, it's in the cheek. And when you look intraorally, you can appreciate that there clearly is a sialolith on the buccal mucosa. Where this becomes difficult is if there is overlap. So if this occurs in the submandibular gland, you might see a radiopacity next to the mandible. And if that's the case, you either can do an occlusal radiograph to try to find that submandibular sialolith, or a CT that will show you that there's a sialolith there. So it's always good to kind of consider that a X-ray is a two-dimensional image, and you need to think about the human structure in 3 dimensions. This also brings up a point that if you have a hard mass in the buccal mucosa or the labial mucosa, you can do a soft tissue radiograph, which means you don't have to include the teeth. You can simply put your X-ray sensor on one side of the soft tissue, capture your radiograph through the soft tissue, and that will give you a diagnostic image. Is this truly a sialolith, or is it hard for another reason? Is it just firm and it's a soft tissue lesion? Soft tissue radiographs can be helpful to verify that you certainly are dealing with a sialolith. And here's an example of what I was speaking to about, a radio opacity in the mandible. If you're not careful, you might think that this radio opacity is within the body of the mandible itself. But if you do a occlusal radiograph or a CT, you can appreciate that the sialolith is clearly not within the mandible, but is separate and is within the submandibular duct, which is what we expect. Here is another case of a submandibular sialolith that I have seen at our hospital. This is what a sialolith looks like clinically. This was in the upper lip, and you can see that this is clearly beautifully laminated, where we have all of these different layers that were laid on top of one another. And that's because there's usually a nidus, or a central layer that could be a mucus plug, it could be bacterial debris, and then over time, additional bacterial debris and calcified salts will layer on top of it, and it will expand from the inside out and create a sialolith. You can also appreciate that the adjacent gland exhibits quite a bit of inflammation, and that's due to this obstruction. This obstruction is causing backflow and leading to inflammation within the gland. There's a few ways to treat these. Most commonly is surgical excision. If the duct needs to be open, then obviously you need to repair the duct to prevent mucocele. There is something called extracorporeal shockwave lithotripsy, and that is when they use sound waves from outside of the body to try to break up this stone. And if you can break up the stone into small enough pieces, then it can be passed through the salivary duct and swallowed unincidentally. The most important concept here is that you have to evaluate gland function to determine if it should be removed as well. If the gland becomes so inflamed that it scleroses and fibroses and becomes non-functional, then it needs to be removed as well. You saw in the case of the young child that had the submandibular duct obstructed by that small little sialolith, that there already was swelling of his submandibular gland, and that was because of this obstruction. Fortunately for that patient, upon the sialolith being secreted, the submandibular gland went back to normal and was fully functional. In some cases, the damage is already done and the gland must be removed because of the fibrosis and the sclerosis. Now we'll be discussing our inflammation of the salivary glands, starting with acute sialadenitis. Sialadenitis in general, as I mentioned before, is inflammation of the salivary glands, salivary glands, itis, inflammation. Acute sialadenitis is often bacterial in origin, either Staph aureus or strep. These are often penicillinase producing, so when deciding what antibiotic to use, it will need to be broad spectrum and will need to be modified to make sure that it can withstand that penicillinase being produced by the bacteria. This is most commonly caused by retrograde infection, where the bacteria is able to travel backwards through the duct to get to the gland. This is most commonly caused by xerostomia. If the patient is not producing saliva to continuously wash out their duct, then obviously that's going to allow for an opportunity for invasion, where they're able to enter the salivary duct tunnel and then travel back to the gland because there's nothing forcing it out. There's no saliva forcing it out. Another consideration is general anesthesia, and they call this surgical mumps because the patient will look like their glands are very, very swollen, and it's not caused by a virus, as is the case for mumps, but caused by surgery. So it looks like swollen glands after surgery. And this is because patients are given anti-parasympathetic blockers to prevent excess secretions at the time of surgery. Again, if the patient isn't secreting saliva, which during surgery we don't want secretion of all of these products, there can be an opportunity for bacteria to travel backwards along the duct and get to the gland. The clinical appearance is a diffuse, painful, tender, often unilateral, but certainly can be bilateral swelling of the gland. And that's because we know that when there is inflammation and infection, we're going to get a red and painful and tender mass. The overlying skin may be warm to touch and erythematous. These are all of our hallmarks of inflammation: red, warm, painful. And in addition, because there may be a systemic aspect of this infection, the patient may have a low-grade fever and may have trismus because of this inflammation and infection, leading to the inability of full mouth opening due to what's going on. The kind of slam dunk sign is purulent exudate from the duct orifice, which you can really appreciate in this picture here, supplied by Dr. Salama. So to treat this, you perform culture and sensitivity to figure out what antibiotic would be best to treat this, again, because many are penicillinase producing. And you adjust an antibiotic depending on the results, and then patients usually respond pretty well. In contrast, chronic sialadenitis is a separate process. It certainly can follow acute sialadenitis. If acute sialadenitis leads to long-term damage and long-term inflammation recruitment, it can happen, but this can also be due to ductal damage or obstruction, as we've already kind of talked about so far. The blockage can be due to sialolith. It can be due to fibrosis from surgery. So if surgery is performed in the area of a duct, the subsequent scar and fibrosis that occurs as normal healing can squeeze or compress the duct, leading to backflow, leading to chronic inflammation. That same compression around the duct or near the duct can be from a tumor. So if there's a tumor in the area pressing on the gland or pressing on a duct, it can lead to the inability of sufficient salivary secretion and can lead to chronic inflammation. And here's what it's going to look like under the microscope. You can appreciate that all of these blue dots are lymphocytes, and around the salivary ducts, we have this very pink fibrosis. And this is what we will call under the microscope chronic sialadenitis. Sometimes we'll say chronic sclerosing sialadenitis. Eventually, over time, you'll see less of the lymphocytes and more of the sclerosis and fibrosis. It can become so bad that the sclerosis and fibrosis completely replaces the gland, and it essentially becomes non-functional. If there is an acute component to chronic sialadenitis, you can treat with antibiotics, but most of the time it occurs for a different reason. And the most common treatment that we recommend is warm compresses, massaging the gland by rubbing it and trying to promote the secretion, and sialagogues if there's functional reserve. So if you can increase the salivary flow and the amount of saliva, it may be able to push through the compression of the duct or whatever's obstructing it and go back to a normal flow. Unfortunately, if the gland is not functional, the duct needs to be tied off, or the gland itself needs to be removed if it's completely sclerosed. We will often encourage patients to use a sugar-free hard candy. By constantly having that simulation, it can lead to the parasympathetic response where saliva is created due to that constant stimulation. And like I was saying with Pavlov, if something's in the mouth, the body wants to digest it, and you can try to create more saliva to push through the obstruction and try to get rid of this chronic sialadenitis. Sialorrhea is excessive salivation, and there are many possible etiologies as to why this may happen. Now, the key here is that there has to be an objective measurement. You have to have true excess saliva. And true excess saliva can be seen in a new prosthesis. If anyone has delivered a complete denture, the body in a new denture wearer feels like it's food. They have something in their mouth, the signals are being stimulated, and the patient is going to produce a lot of saliva. That's why it's important when you're delivering a new prosthesis to tell the patient that they may drool a little bit. Gastric esophageal reflux disease can lead to sialorrhea. The body produces excess saliva as a protective mechanism for the acid. Rabies, which is where this picture's from, in my dental school, in our infectious disease course, we actually watched this video, and it's horrifying. This is an Afghani farmer that was bit by a bat and become rabid, and unfortunately was diagnosed when it was too late. And the video from the 50s, it had the old school kind of British narration, showed you the subsequent effects of rabies on this man, and it's really pretty horrific. But the classic foaming at the mouth does occur in rabies. Heavy metal poisoning can lead to sialorrhea. It can be medication-related sialorrhea. Most of the time, you get medication-induced xerostomia or lack of saliva, but there are certain medications that can promote parasympathetic innervation and lead to sialorrhea. And then also idiopathic, where we don't know why. But the key here is objective measurement, as I mentioned. You have to prove that the patient has true excess salivation, and you have to rule out poor neuromuscular control. Now, if the patient has a neuromuscular degenerative condition, they may be drooling simply because they can't support their facial muscles. If they can't support their facial muscles, then the saliva may accidentally come out of their mouth. And you do see this sometimes with people with neuromuscular degeneration, such as muscular dystrophy and other conditions like that, where they may carry around a towel to wipe away their saliva. And it's not because they're producing more saliva, but it's because they can't contain the saliva within their mouth due to poor neuromuscular control. And finally, the psychological confounder. In fact, there is literature to support that the majority of reported sialorrhea are perceived sialorrhea, where the patient feels like they have excess saliva and they truly do not have objective increase in salivary control. Interestingly, I had a patient in residency that came to the emergency department that was constantly spitting in a basin and saying that his sister put a voodoo curse on him in Haiti, and he felt that that led to him having too much saliva. He did not have true objective increase in saliva, but he certainly did have a psychological confounder in that he felt that he had a voodoo curse that was causing him to have excess saliva. Sialadenosis or sialosis is a slowly evolving swelling of the parotids with or without pain. Most of the time it's without pain, but you can appreciate that we have a unilateral swelling in this patient here. And there are many different causes of sialadenosis or sialosis. They can be endocrine, nutritional, or neurogenic, non-inflammatory. The most common that are implicated are diabetes, malnutrition from eating disorder, and psychotropic medications. This patient pictured here had both diabetes and an eating disorder, which led to this sialosis. The main differential diagnosis here is Sjogren's syndrome. And with that, you have to kind of get the full workup. So you need to ask the patient, are they experiencing dryness in their eyes and their mouth? And if they aren't, then you want to move towards a sialosis. And a full discussion of Sjogren's syndrome can be found in my Sjogren's syndrome video. A biopsy of these patients, which is not necessary. These patients do not need to undergo biopsy, but if there is concern for tumor, which with proper imaging and palpation should be excluded, but occasionally biopsy is undergone, you're going to see hypertrophy of acini. So the glandular elements are going to look about 2 to 3 times larger than normal. And there's going to be no significant inflammation, as opposed to Sjogren's syndrome, where you're going to see the classic periductal lymphocytic infiltrate. Next is adenomatoid hyperplasia. And this is very rare. We don't see this very commonly, but the patient will present with a tumor-like mass, usually of the hard or soft palate. This patient in this article presented with a tumor-like mass of the lower lip. This to me would be very concerning. There are a lot of tumors that are kind of at the top of my differential for this presentation. However, when a biopsy is performed, all we see on the biopsy is normal mucus acini, but maybe we see a little bit more than we'd expect in that area. So we expect to see mucinous acini in the palate and in the lip, but on biopsy, we might just see more of them. They are not increased in size, unlike sialosis. They are not increased in size. They are completely normal, but there's just more of them. After diagnosis, there is no treatment required for these patients. There is no tumor transformation. It's kind of this anomalous increase in number of glandular elements. The key here, though, is that you have to ensure that this is not a tumor because it's going to look like a tumor. And you have to do your biopsy. And once you get back adenomatoid hyperplasia, it's very rare, go buy a lottery ticket, and then you can follow the patient, but it will likely stick around. Now for cosmesis, you certainly can remove and recontour the lip or palate, but really there's no treatment indicated after a diagnosis has been established. Here's an example from that article where these mucinous acini, there are a lot of them, but they look very normal. And finally, we have a very interesting entity called necrotizing sialadenosis. Now, we're not sure why this happens. We think maybe it's due to ischemic necrosis. We've seen this after in palatal injections. We've seen this after trauma. So the thought is maybe there is a necrotic event that causes the vasculature to shut down, leading to this necrotizing sialadenosis. It looks very scary clinically and under the microscope. So you have to be very careful with these lesions, but there's a pretty classic clinical course, and experienced microscopists that are familiar with this condition are able to differentiate it from malignancy under the microscope. But initially, it can look very scary. Most of these occur on the posterior hard palate / anterior soft palate at kind of the hard palate, soft palate junction, more common in adults with a male predilection. The kind of classic clinical course for this entity is a painful swelling of the palate, which can be unilateral or could be bilateral. And after 2 weeks, this painful swelling resolves, and the patient may say, a piece of my palate or a piece of the roof of my mouth fell off. After this piece of their palate, quote, fell out, you're going to see a sharply marginated ulcer. And we know that ulcers can be kind of concerning, and these can look very ugly looking. Sometimes we can see palatal bone through these ulcers. It can ulcerate down to bone, where again, we may be thinking about malignancy. So we were thinking about malignancy with the painful swelling. Now we're thinking about malignancy with this ulcer. And both of them need to be distinguished from a malignant process. There are non-elevated margins and minimal erythema. It's a really pretty clean ulcer. And once the piece has, quote, fallen out, it's completely painless. So the patient's pain does dissipate once the swelling kind of falls off. Here's the kind of before picture, where in this case reported in the literature, we have bilateral palatal swellings that are very painful to the patient. And this is what it looks like once it falls off. Very sharply demarcated ulcer here, where we can draw a really nice border around it. And there's really no erythema. There's not a lot of redness to this at all. This was in a patient with an eating disorder. The purging process could have led to an ischemic necrosis, leading to sialometaplasia. It's not common to get these palatal swellings, get pictures of them. Oftentimes, the patient doesn't report until after the piece of their palate has fallen off, because they're concerned. Obviously, they see this ugly looking thing in their mouth and they feel as though part of their mouth fell off, and that can be understandably very alarming. But occasionally you may see a swelling for before this happens. And here's a photomicrograph with the 2 key findings under the microscope, where we have necrotic acini. So we saw in that picture of adenomatoid hyperplasia what normal gland structure should look like. This maintains the shape of our acini in our lobules, but they're completely necrosed. There are no glandular cells, it's just necrotic debris. And then we also have the ducts that normally have a ductal epithelial look, but become metaplastic, and that's the metaplasia portion of this. And here we have some more photomicrographs. Up top, we have our necrotic acini, and we can see that the fibrous septae that separate the acini remain. So it's kind of like a ghost, where we have the outline, but the cells inside of these acini are completely dead. It's all necrotic debris, but we can see that there probably were glandular structures or acini in this area at some point in time. So that is the necrotizing portion, where you've got the necrosis. And then down here we have the metaplasia, which is the ducts. So this is kind of a normal duct. This is what we expect to see. And then here we have metaplastic ducts, where we know that metaplasia means changing from one type to another. So it goes from a ductal epithelial appearance to a more squamoid appearance. And this is where someone unexperienced might become concerned, where they might think that this is a mucoepidermoid carcinoma or even a squamous cell carcinoma. So a painful swelling clinically is concerning for malignancy. We think about things like adenoid cystic carcinoma. And then the microscopy is also kind of concerning for malignancy because we see these squamous islands in areas that they shouldn't be. So this is a really, really important entity to know, because you do not want to mistake it both clinically and microscopically for a malignancy. For necrotizing sialometaplasia, absolutely no treatment is indicated. If the patient's uncomfortable, you can do some palliation, either magic mouthwash or pain control with over-the-counter pain medication. It has an excellent prognosis. Once it happens, it kind of heals over. That ugly-looking ulcer will go away in about 5 to 6 weeks, and the patient's palate will look completely back to normal. Thank you for your attention. I really appreciate it. If you have any questions, please feel free to reach out, and have a nice day.
Thanks again for watching. If you enjoy these more long-form lecture-style videos, make sure that you hit the subscribe button so that you don't miss any in the future. Thanks again for watching, and be well.